Hello everyone, very good evening to all. Welcome you all to this exam analysis of physiology questions, FMGE July 2025 paper discussion. Overall, there were around 11 to 12 questions from physiology. They were all of moderate, not even difficult, we could say, almost moderate type of questions, not very easy, not very difficult, moderate type of questions. But more importantly, most of them were clinically relevant questions. So it was like a medicine question, but if you go into the concept, it was actually a physiology question. So once you are thorough with your physiology basics, if you were thorough with your physiology basics, easily you would have answered these questions. And all these questions we had discussed in our classes, FMGE classes. We had online and offline classes. All the topics we had completely discussed. So let's move on to the questions without any delay. Yes, over to the first question. Yes, in case of any discrepancy, kindly let me know in the comment box, because these are the type of questions which were collected from our students. So whichever concept you were able to recollect and tell us, we are just reproducing it here. So just the recall pattern of questions, there will be discrepancies. In case, kindly let us know in the comment box. Thank you so much. Over to the first question. Which among the following best describes neuropraxia? Yes, first question itself, there was a little bit controversy. Let's discuss the concept and we'll go into this question. So we had discussed about neuropraxia. What is neuropraxia? In different types of nerve injuries. So we know there are Seddon's classification of nerve injury and Sunderland's classification of nerve injury. According to Seddon's classification of nerve injury, how did we classify this nerve injury as? Three types: neuropraxia, axonotmesis, and neurotmesis. You can see four different images here. I'll just zoom into the first one. So this one is a normal intact nerve. Nothing has been injured. You can see this black line is the axon here. The covering sheath, the neural sheath or the myelin sheath is blue in color. And the encapsulating layers of endoneurium and perineurium, epineurium. So the first one is an absolutely normal neuron. Nothing has been injured. The second one that you see, this is neuropraxia. Praxia means disturbance in conduction. There is a disturbance in conduction because the nerve is not cut, but it could have been compressed. Compression injuries, it is just compressed, nothing has been cut. So anatomically this is all right. Anatomically intact. Anatomically it is intact. It means the axon and the myelin sheath, nothing has been cut. In most of the cases of neuropraxia, it maintains the anatomical intactness. Nothing is usually cut here. And example, compression injuries, any compression form of injuries like wrist drop, Saturday night palsy, which we also call it as honeymoon palsy. So any compression injuries fall under neuropraxia. This is neuropraxia. But in some cases, there can be a damage to the myelin sheath also. In most of the cases, there is intact axon and intact myelin sheath. But some cases, in some mild to moderate type of neuropraxia, there could be a damage to the myelin sheath, but that is also a completely reversible damage. It is not an irreversible damage. It is a mild damage. There could be a mild damage, very rarely, and that also is reversible damage, completely reversible damage. It is not an irreversible myelin damage. It could be a mild form of reversible damage, can be seen. I think that was the controversy in your paper also. Some students said the option was intact axon, and some of them said there was also damaged nerve sheath. So whatever it is, if you have had only intact axon, we will go for this answer, option A, because damaged axon is definitely not the answer. Option C also, damaged axon, is definitely not the answer. None of the above cannot be the answer. So we'll go with intact axon. Even if you have had plus damaged nerve sheath, it could be a very rare mild form of damage to the nerve sheath. Even if that was in the option, we cannot go with option B, C and D. So we have to go with option A only. if you have had this damaged nerve sheath, or if it was not there in the option, anyways the answer would be option A, intact axon. The next form of injury is axon orthmesis. Orthmesis means cut. Axon orthmesis means the axon has been cut. So there is injury to the axon here. So this is a moderate form of injury where axon plus sometimes the myelin sheath could be injured. Example, nerve crush type of injuries. This is a moderate type of injury. The worst form of injury is neurorthmesis. Neurorthmesis means the whole nerve has been cut. Neurorthmesis, you can see it's completely cut here. This is the worst form of injury, neurorthmesis. Example, transection injuries. Transection injuries. This is Seddon's classification of nerve injuries. So going back to the question, please remember neuropraxia, most of the cases axon and myelin sheath is completely intact, but in some cases there could be a mild reversible damage to the myelin sheath. Since the options were like this, if this was there in the option or this was not there in the option, we have to go with option A only. So we'll go with answer A, intact axon plus damaged nerve sheath present. Also we have to go with the same answer only. Yes. Moving on to the next question. A woman from Delhi travels to Ladakh. Ladakh is a high altitude place. So the question is about something related to high altitude. Soon after arrival, she develops breathlessness, headache and lightheadedness. What is the primary underlying mechanism responsible for her symptoms? High altitude. As you climb up high altitude, as you go higher and higher, atmospheric pressure decreases. Atmospheric pressure decreases. When atmospheric pressure decreases, definitely the partial pressure of gases also will decrease. Partial pressure of oxygen decreases, and this we call it as hypoxia. So at high altitude you will experience hypoxia. So this person is experiencing hypoxia. In hypoxia, hypoxia is a very potent stimulus for your peripheral chemoreceptors. So this hypoxia can stimulate your peripheral chemoreceptors, the respiratory chemoreceptors. As a result, the person will start to breathe more. You will hyperventilate because your respiratory chemoreceptors are stimulated. You will hyperventilate. When you do like that, you send out more carbon dioxide because respiration is a process where you send out CO2. When you do hyperventilation, you automatically send out more CO2. So there is CO2 washout. You're sending out CO2. More the CO2 goes out. CO2 is a volatile acid. Carbon dioxide is considered as a volatile acid. When you send out more acid, automatically your body will go to alkalosis. And this is because of the lung hyperventilating. So we call it as respiratory alkalosis. Respiratory alkalosis. So at high altitude, because you send out more CO2, acid goes out, body goes in for alkalosis. So we go in for this option. Respiratory alkalosis is the mechanism underlying all these symptoms in this patient. Over to the next question. A young patient experiences shortness of breath during exercise, winter. So two important factors are here. One is exercise and the other is she's exercising in winter, something exposed to cold air, which subsides after using salbutamol. Salbutamol is a bronchodilator. So when you give bronchodilator, the symptoms are getting relieved. What is the most likely explanation for this condition? So this is about exercising in winter. On exposure to cold air in winter. What does this cold air do? Automatically when you exercise, that also in winter, you have to do mouth breathing only. Because in winter, you're in cold air, when you do exercise also, you have to utilize your mouth. So there is mouth breathing. When you do mouth breathing, you like take in more of cold air and that gives you a dryness. And this dryness in the respiratory tract, because of this dryness, it leads to mast cell degranulation, and this begins to release factors like histamine, and histamine is a very potent bronchoconstrictor, and this histamine produces bronchoconstriction. So there is exercise induced bronchoconstriction which was triggered by cold air. Histamine, mast cell regranulates to release histamine, and this histamine has caused bronchoconstriction. So we go in for this option C. Exercise induced bronchoconstriction triggered by cold air. We cannot go with option A because there's no vagal stimulation here. Even if so, exercise will cause sympathetic stimulation, not vagal stimulation. Decreased cardiac output stimulating the baroreceptors. So we cannot go with this option also. All airway hyperactivity due to cold induced asthma exacerbation. There's no history of asthma in the case, and moreover it is due to exercise in winter, and overall it is relieved by salbutamol. So that has nothing to do with these baroreceptors. So salbutamol is a very potent bronchodilator, and this bronchoconstriction effect was reversed by the bronchodilator salbutamol. So we go with option C. Over to next question. Which of the following changes is seen in JVP in AF? What is AF? Atrial fibrillation. What is atrial fibrillation? See, this is normal beating heart. In atrial fibrillation, your heart starts to beat like this. It is almost vibrating, that is fibrillating. So the heart rate is very high and your heart is fibrillating like this. So at that time, you have absent A waves, because in JVP, these are the different waves that you see in JVP. First of all, what is JVP? JVP is a record of right atrial pressure. This is an indirect method of measuring right atrial pressures. So when you want to record the right atrial pressure, we can just look at the jugular venous pulsations, because the jugular veins directly drain into the right side of the heart. So JVP means we are recording the right atrial pressure. And these are the different waves that come up. A wave, C wave, X wave, V wave and Y wave. One easy way of remembering these waves is JVP is a record of right atrial pressure. It's not ventricle, it's atrial pressure. So correlate the waves of JVP only with atrial events. Not confusing with ventricular events, only with atrial, because JVP is a measure of atrial events. So atrial events only we are going to take. A for atrial contraction. When atrium is contracting, you get the A wave. C for tricuspid. C for cuspid. C. Tricuspid bulge. During isovolumetric contraction phase, the tricuspid valve will bulge. That gives rise to C wave. X for atrial relaxation. V for atrial venous filling. And Y for atrial emptying. So we have correlated JVP waves only with the atrial events. So A wave in JVP indicates atrial contraction. When your heart is beating normally like this, you have proper atrial contraction. There is a proper A wave. Just think, if your heart is fibrillating like this, there is no proper contraction. When there is no proper contraction, you will not see this A wave. So A wave is absent in atrial fibrillation. So we go with this option A, absent A waves. Next question. Which vitamin deficiency can cause lactic acidosis? So lactic acidosis is related to thiamine, because in thiamine deficiency, pyruvate cannot be converted to acetyl-CoA. When there is thiamine deficiency, through this pyruvate dehydrogenase complex, pyruvate cannot be converted to acetyl-CoA in thiamine deficiency. If pyruvate is not converted to acetyl-CoA, its fate would be conversion into lactate. And this would cause lactic acidosis, which is a type of metabolic acidosis. Accumulation of this lactate results in lactic acidosis. So we go with option D, thiamine related to lactic acidosis. Over to next question. A 28-year-old woman presents with progressive fatigable weakness affecting the eyelids and extraocular muscles, ptosis, diplopia, double vision by the evening. Neurological examination reveals normal reflexes, normal sensation, and strength improves after rest. All this, yes, ISPAC test is positive. All this pertains to the diagnosis of, yes, myasthenia gravis. The diagnosis here is myasthenia gravis. In myasthenia gravis, there is autoantibody blocking the acetylcholine receptors of the postsynaptic terminal. Only if you understand the neuromuscular junction and events in the neuromuscular junction, you will be able to do this. So this is a normal neuron and its axon terminal, and this is a muscle. This is the neuromuscular junction. What happens in the neuromuscular junction? Whenever an action potential arrives in the neuron, neuron is located presynaptically. Neuromuscular junction is the synapse. Neuron is before the synapse. So before the synapse, presynaptically in the neuron, when the action potential arrives, this action potential is a voltage which will be sensed by voltage gated calcium channels, and calcium enters inside. What will this calcium do? It will release acetylcholine into the neuromuscular junction, because wherever you have calcium, it can cause movement of the vesicle. So this calcium will move this vesicle which contains a neurotransmitter acetylcholine, and acetylcholine is released into the neuromuscular junction. This acetylcholine binds to the acetylcholine receptors, which are called nicotinic receptors, located on the muscle. Now this is the muscle side. Muscle is located after the neuromuscular junction, after the synapse. So this becomes postsynaptic. And this acetylcholine binds to the nicotinic receptors which are present on the muscle. Once acetylcholine binds to the nicotinic receptors, this will cause action potential in the muscle, and this action potential releases calcium from SR, and this SR releases calcium with the help of a receptor called ryanodine receptor. Ryanodine receptor will release this calcium from SR, and this calcium will cause muscle contraction. Actin, myosin, all that, excitation, contraction, coupling, and muscle contraction. This is how any muscle contracts, and these are the events which take place in the neuromuscular junction. Now, going back to the question, the patient is suffering from myasthenia gravis. What is myasthenia gravis? There is autoantibody against this nicotinic receptor. Autoantibodies against this nicotinic receptor which is present on the muscle postsynaptically. This is called myasthenia gravis. So we'll go back to the question. Autoantibodies blocking the acetylcholine receptors at the postsynaptic terminal. It is not presynaptic, because in the presynaptic you don't have nicotinic receptors. Nicotinic receptors are present in the muscle postsynaptic. And there is another relevant disease related here. If there is any block of this voltage gated calcium channel, if the patient has autoantibodies against this voltage gated calcium channel, this is called Lambert-Eaton syndrome. Lambert-Eaton syndrome. So Lambert-Eaton syndrome is an autoimmune disease affecting calcium channels presynaptically, and myasthenia gravis is an autoimmune disease affecting the nicotinic receptors, acetylcholine receptors, postsynaptically. Clear? So I think the other option speaks about Lambert-Eaton syndrome. We'll move on to the next question. Which among the following hormones in lactating mother is responsible for growth of breast tissue? Actually, if you see, estrogen, prolactin, progesterone, all of them will help in growth of the breast tissue. But specifically when it says in lactating mothers, immediately after delivery, prolactin levels are very, very high. And prolactin is responsible for growth of the breast tissue in lactating mothers, because estrogen, progesterone levels will decrease after delivery. Prolactin increases after delivery, in lactating mother especially, to increase lactation, and that can cause growth of the breast tissue. So of all this, we can go for the best option as prolactin. Prolactin. Go to next question. A 35-year-old man wakes up after sleeping with his arm draped over a chair. So his arm draped over the chair means it has been compressed. He wakes up after sleeping means throughout the night it has been compressed, it has been pressurized. Which of the following accurately describes the order of susceptibility given in this? Pressure. So when you talk about pressure, definitely A fibers are most susceptible to pressure. And we already know that C fibers are least susceptible. So this would be A more than B more than C. So obviously option A. A fibers are most susceptible to pressure. So we go with option A. Go to next question. Which of the following best describes chloride shift? What is this chloride shift? In tissues, when tissues release carbon dioxide, normally tissues release carbon dioxide, and tissues release carbon dioxide into venous blood. So this carbon dioxide enters into the venous blood. What is the fate of this carbon dioxide which enters into the venous blood? It enters into the venous blood RBC. This is venous blood RBC. Once CO2 enters into venous blood RBC, it combines with water to form H plus and bicarbonate. And what is the fate of this bicarbonate? It moves out of the RBC into the plasma. Bicarbonate is an anion. In exchange for this anion, another anion, chloride, enters into the RBCs. This is called bicarbonate chloride anion exchanger shift, or the chloride shift, or the hamburger's shift. And chloride enters into this RBC. So this is what happens in the venous blood RBCs. And this is called as the chloride or the hamburger shift. So we can go with the option chloride enters into the RBC to maintain the electrical neutrality when bicarbonate exists. Yes, just now we saw bicarbonate moves out of the RBC. To maintain the electrical neutrality, chloride will enter into the RBC. Hamburger shift. Go to next question. Which of the following best describes the oxygen hemoglobin dissociation curve in anemia? This is the oxygen hemoglobin dissociation curve, which explains partial pressure of oxygen in millimeter of mercury on x-axis and oxygen saturation of hemoglobin on y-axis. Saturation means hemoglobin is how much bound to oxygen. That is called hemoglobin oxygen saturation. So in this question, this curve is called the oxygen hemoglobin dissociation curve, the normal curve. How will you find out it's a normal curve? At partial pressure of 100, the saturation is almost 97%. So this is a normal curve where where partial pressure reaches 100 millimeter of mercury, your saturation will reach 97%. This curve can be shifted to the right. This is called right shift of the curve. If the curve is shifted to the right, R for right shift and R for release of oxygen to the tissue. Whenever there is a need to release this oxygen to the tissue, curve will shift to the right. So R for release of oxygen to the tissues. So when will there be a need to release oxygen to the tissue? In hypoxia. Hypoxia means tissues are suffering without oxygen. That is called hypoxia. So when the tissue is suffering without oxygen, there is obviously a need to release oxygen to the tissues. So the curve will shift to the right. So in hypoxia, the curve shifts to the right side. What happens in anemia? Hemoglobin is less in anemia. If hemoglobin is less oxygen only can be carried to the tissue. If less oxygen is carried to the tissue, it means tissue suffering from hypoxia. So therefore, the curve will shift to the right side. So in anemia, there is shift to the right side. What are the other factors which cause shift to the right side? Right means something good, something positive. We'll place all positive factors, increasing factors here. Increase in H plus, increase in CO2, increase in temperature, and increase in 2,3-BPG, 2,3-bisphosphoglycerine, 2,3-BPG. So all this can cause right shift of the curve. And in anemia, since oxygen carrying capacity is decreasing, there could be an increase in 2,3-BPG in anemia also. So going back to the question, ODC curve in anemia, shift to the left, definitely not. No shift is also wrong. Downward, there's no shift like that. Shift to the right due to increase 2,3-BPG. Yes, in anemia there could be increase in levels of 2,3-BPG which can cause right shift of the curve. So the best option would be option A. Next question. In malignant hypothermia, a genetic mutation of ryanodine receptor leads to life-threatening reaction to certain anesthetic agents, which is a primary ionic abnormality here. Yes, we have already discussed this in neuromuscular junction. I told you sarcoplasmic reticulum releases calcium through the ryanodine receptor. So ryanodine receptor is responsible for release of calcium. Excessive activity of this ryanodine receptor, overactivity of ryanodine receptor can cause increased release of calcium. More the calcium, more the muscle will contract. More the muscle contracts, more heat is produced. When more heat is produced inside the body, this we call it as malignant hyperthermia. So in malignant hyperthermia, there is increased calcium. When there is more calcium, more contraction, more heat. Malignant hyperthermia. And how will you treat this? Ryanodine is the problem, so you give a ryanodine receptor blocker. Dantrolene sodium. Yes, dantrolene sodium is used in the treatment. Dantrolene sodium, which is a ryanodine receptor blocker. So going back to the question, in malignant hyperthermia, mutation of ryanodine receptor. So there is increased calcium release from sarcoplasmic reticulum. It's not related to sodium, not related to potassium, not related to chloride. So the best answer would be option D. Increased calcium release from the sarcoplasmic reticulum. Yes, any doubts? You can always follow us on Instagram and the YouTube comments. You can give us your suggestions. Thank you so much for joining with me in this session. Hope it was a useful session to all of you. Yes, you have done your best. Don't worry, God will do the rest. Thank you so much.